Good day, everyone. Today, I will discuss to you about the types of atrial dysrhythmia with their characteristics, etiology, pathophysiology, clinical manifestation, medical management, diagnostic and laboratories, and the nursing management. So before we tackle about atrial dysrhythmia, I will be showing to you a video about the electrical conduction in the heart.
So, electrical conduction in the heart refers to the electrical signals that go from cell to cell in the heart. This happens in the form of action potentials, which get sent out by the pacemaker cells in the heart. The pacemaker cells, also called conducting cells, are a relatively tiny group, only about 1% of the heart cells, but they're a pretty influential minority. Their special ability is that they're autorhythmic, which means that they're able to continually generate new action potentials that go out to the rest of the heart, which are the other 99%. This is different from how it works in skeletal muscle cells, which get their action potential signals directly from neurons. The cells that receive the cardiac action potential from the pacemaker cells are called myocytes, and they make up the myocardium, which is the muscular middle layer of the heart. Myocytes are also called contractile cells, because they contract and that's how the heart pumps blood. Action potentials are initiated by depolarization, which is the opposite of polarization. In this case, polarization is when there are more positive ions outside the cell than inside. This difference in charge is called the membrane potential, and is negative since there are more positive ions outside the cell. So depolarization is when the membrane potential gets smaller, making a cell slightly more positive than it would normally be. Imagine a negative, gloomy cell experiencing a brief moment of joy. If one cell after another depolarizes, then there's a depolarization wave, which is just like a crowd of people doing the wave at a football stadium. So there are a group of pacemaker cells in the sinoatrial node, or SA node, which is a small sinus or cavity tucked up into the right atrium. During each heartbeat, one pacemaker cell out of the group will automatically depolarize first. In fact, each heartbeat might be led by a different cell in the group, but eventually at least one of them will fire because they're all autorhythmic, meaning that every pacemaker cell has the ability to self-generate a new action potential, given enough time. So as a group, the pacemaker cells of the SA node act like a drill sergeant that gives orders to the rest of the heart. They decide when the heart contracts and when it relaxes, so they set the heart rate. The depolarization wave that comes out of the SA node moves really fast through the pacemaker cells throughout the heart, and moves more slowly through the atrial and ventricular myocytes. Some pacemakers lie along atrial internodal tracts, also called Bachmann's bundle, which connects the SA node to spots in the right and left atria, so that the depolarization wave can quickly reach atrial myocytes in both atria. When the atrial myocytes get depolarized, they contract, which pushes blood from the atria into the ventricles. While this is happening, the depolarization wave also travels from the SA node through the pacemaker cells to the atrioventricular or AV node. Conduction velocity slows way down at the AV node, and this happens for two reasons. First, the AV nodal cells have very small diameters, which increases resistance to electrical flow. And second, the AV nodal cells use the relatively slower opening calcium ion channels rather than the faster opening sodium ion channels. The AV node is the only point where an electrical signal can go from the atria to the ventricles. And since the depolarization wave causes muscle contraction, this slight conduction delay is crucial in allowing the ventricles to have plenty of time to fill with blood before they contract. So let's say that for some reason the conduction through the AV node is sped up. Well, in that situation, there's less time for ventricular filling, and so there'd be a decrease in stroke volume and cardiac output. From the AV node, the depolarization wave travels through the conducting system of the ventricles. First, it goes to the bundle of His, and then into the left and right bundle branches and into the Purkinje fibers. The Purkinje fibers are the final bit of conductive tissue that spread the depolarization wave to the rest of the heart. The His-Purkinje system conducts the depolarization wave really fast, and this is important because it makes the heart contract in a coordinated way. If the timing was slightly off and the ventricles didn't contract all at once, blood would sort of slosh back and forth, rather than getting forcibly pushed out to the lungs and body. One really cool thing about the heart is that if the pacemaker cells in the SA node fail to fire, there's not only a plan B, but a plan C and plan D as well. Pacemaker cells in the SA node have short action potentials and short refractory periods. So right after depolarizing, they want to depolarize again. That's called the firing rate. And at rest, the SA node has a firing rate of 60 to 100 depolarizations per minute. It turns out, though, that there are pacemaker cells in other parts of the atria that have a slightly slower firing rate of 60 to 80 depolarizations per minute. There are also pacemaker cells in the AV junction that have a firing rate of 40 to 60 depolarizations per minute. And pacemaker cells in the ventricles, specifically in the bundle of His and Purkinje fibers, that have a firing rate of 20 to 40 depolarizations per minute. So if the SA node fires on time, then it resets all of the other pacemaker cells, and that's why it sets the pace. If the SA node doesn't fire, then atrial pacemaker cells finally get a chance to start firing, and they get to set the pace, resetting the pacemaker cells in the AV junction and ventricle. If the atrial pacemaker cells fail, the AV junctional pacemaker cells take over. And finally, if all the other pacemaker cells fail, then the ventricular pacemaker cells start pacing the heart. Once any of these groups of latent pacemaker cells steps up, it's called an ectopic pacemaker, or ectopic focus, meaning that the pace is being set from a place other than the usual spot, which is the SA node. Alright, as a quick recap, pacemaker cells in the SA node send a depolarization wave through the atria so they can contract together, as well as to the AV node where there's typically a delay so that the ventricles can fill with blood. From there, the depolarization wave races down the bundle of His and Purkinje fibers and spreads out through both ventricles, which allows them to contract together. If the SA node fails, other pacemaker cells in the atria, AV junction, and ventricles are ready to step in to take over.
So what is atrial dysrhythmia? Atrial dysrhythmia is a disorder of the heart rate or heart rhythm, such as beating so fast or beating too slow, or irregular heartbeat. This usually feels like a fluttering in the chest or a feeling of a skipped heartbeat. Dysrhythmias are caused due to the problems with the heart's electrical conduction system, such as abnormal or extra signals might occur, or the electrical signals that can be blocked or slowed down or can even travel in new or different pathways through the heart. Types of atrial dysrhythmias. Premature atrial contractions. This type of dysrhythmia occurs when an electrical impulse starts in the atrium before the next normal impulse of the sinus node. Premature atrial contractions characteristics. Ventricular and atrial rate depends on the underlying rhythm. Ventricular and atrial rhythm irregular due to early P waves, creating a PP interval that is shorter than others. This is sometimes followed by a longer than normal interval, but one that is less than twice than the normal PP interval. This is what we call non-compulsory pause. QRS shape and duration. The QRS that follows the early P wave is usually normal, but it may be abnormal or it may be absent. P wave, an early and different P wave may be seen or may be hidden in the T wave. Other P waves in the strip are consistent. PR interval. The early P wave has a shorter than normal PR interval, but still between 0.12 and 0.20 seconds. P is the QRS ratio. It is usually 1:1. The etiology or causes of premature atrial contractions are caffeine, alcohol, nicotine, stretched atrial myocardium, anxiety, hypokalemia, hypermetabolic state, and atrial edema. Pathophysiology of premature atrial contractions. In the premature atrial contractions, irritants such as drugs like cocaine, anxiety, caffeine, and too much consumption of alcohol, it stressed and irritates atrial cells. An atrial cell outside of the SA node initiates depolarization. When the depolarization waves are sent out, atria contract too quickly. So in short, a particularly stressed out atrial cell can send out depolarization waves that can contract the atria too quickly, and that's an early or premature atrial contraction. Clinical manifestation of premature atrial contraction: a flutter in the chest, fatigue after exercise, shortness of breath or chest pain, lightheadedness or dizziness. Medical management: if the premature atrial contractions are infrequent, no treatment is necessary. Medical management is directed toward the underlying cause, such as reduction of caffeine, reduction of alcohol consumption, less stress, and correction of hypokalemia. It focuses more on lifestyle changes of the patient. Prognosis is dependent on the underlying cause of the premature atrial contractions and the presence of structural cardiac disease. Many idiopathic premature atrial contractions are relatively benign in the short term, although they can be associated with an increased risk of cardiac and all-cause mortality if they occur frequently. The next type is atrial fibrillation. Atrial fibrillation, also known as AFib, is a term to describe a disorder of the heart. It is a result of an abnormal heart impulse formation that occurs when structural or electrophysiological abnormalities alter the atrial tissue, causing a rapid, disorganized, and uncoordinated twitching of the atrial musculature. Atrial fibrillation characteristics: ventricular atrial rate. Atrial rate is 300 to 600 bpm. Ventricular rate is 120 to 200 bpm in an untreated atrial fibrillation. Ventricular atrial rhythm is highly irregular. The QRS shape and duration is usually normal but may be abnormal. P wave: no discernible P waves. Irregular undulating waves that vary in amplitude and shape are seen and referred to as fibrillatory of F waves. The PR interval cannot be measured, and the P-QRS ratio is many is to 1. The etiology or causes of AFib are high blood pressure, heart attack, coronary artery diseases, abnormal heart valves, heart defects, an overactive thyroid gland, exposure to stimulants such as medications, caffeine, tobacco, or alcohol, sick sinus syndrome, lung diseases, previous heart surgery, viral infections, stress due to surgery, and sleep apnea. Pathophysiology of atrial fibrillation. Precipitating factors are cardiovascular diseases, obesity, diabetes, excessive alcohol consumption, and genetics, which is under the predisposing factor. These factors stress the cells in the atria, which leads to tissue heterogeneity, or the cells start taking in different electrical properties. Conduction in the atria becomes unpredictable and overrides the sinus node. Mini contractions occurs that makes the atria look like quivering. When an AFib only lasts less than a week, it probably means the tissue is still relatively healthy. But when an AFib occurs for a longer period of time, it stresses the atrial cells more. It causes scarring of the atrium, and the atria cannot contract, and the blood becomes stagnant and forms blood clots. These blood clots travel into ventricles and pumped out of the body. It can lodge to the brain and cuts off blood flow, which eventually leads to stroke. Clinical manifestations of AFib: palpitations, weakness, reduced ability to exercise, fatigue, lightheadedness, dizziness, shortness of breath, and chest pain. Diagnostic and laboratories: electrocardiography. It is performed to verify the atrial fibrillation rhythm. The next one is transthoracic echocardiogram. It is performed to identify the presence of valvular heart disease. It provides information about left ventricular and right ventricular size and function. Next is the chest X-ray. It is used to evaluate pulmonary vasculature in a patient suspected of having pulmonary hypertension. The next is Holter or vent monitoring. And lastly, electrophysiology study. Physiology, prognosis. Seeking treatment and maintaining regular visits with a physician can typically improve the prognosis when you have AFib. According to the American Heart Association, 35% of people who don't receive treatment for AFib can be at risk for stroke. The AHA notes that an episode of AFib rarely causes death. The next type is atrial flutter. In atrial flutter, your heart's upper chambers, the atria, beat too quickly. This causes the heart to beat in a fast, regular rhythm. Atrial flutter is similar to atrial fibrillation, a common heart rhythm disorder. However, the rhythm in your atria is more organized and less chaotic in atrial flutter than are the abnormal patterns common with atrial fibrillation. Atrial flutter characteristics. Ventricular and atrial rate. Atrial rate ranges from 250 to 400 bpm. Ventricular rate usually ranges from 75 to 150 bpm. Ventricular and atrial rhythm. The atrial rhythm is regular. The ventricular rhythm is usually regular but may be irregular because of a change in the AV conduction. PRS shape and duration. Usually normal but may be abnormal or absent. P wave, sawtooth shape. These waves may make it difficult to determine the PR interval. PQRS ratio, 2:1, 3:1, or 4:1. Etiology or causes of atrial flutter. Ischemia, hypertension, cardiomyopathy, abnormal heart valves, hypertrophy, alcohol, stimulants such as cocaine, caffeine, amphetamines, diet pills, and cold medicines. Pathophysiology of atrial flutter. So normally, an electrical signal is sent out from sinus node in the right atrium, and then propagates out through both atria, causing the atria to contract. Usually, that signal moves in one direction from the atria to the ventricles through the AV node. It then moves down to the ventricles and causes them to contract shortly. After each ventricle contraction, the ventricle has to wait for another signal from the sinus node. With atrial flutter, a reentrant rhythm starts in either the right or left atrium. Reentrant signals loop back on themselves, overriding the sinus node and setting up an endless cycle that causes the atria to contract again and again at really fast rates. In the underlying disease like ischemia that makes the heart cells more irritable, which can change whole properties like refractory period, and thus make it more likely reentrant circuits develop, and establishes endless loop of stimulation which causes the atria to contract at fast rates, and thus makes atrial flutter occurs. Clinical manifestations: chest pain, shortness of breath, anxiety, palpitations, feeling faint or lightheaded, and syncope. Medical management of atrial flutter. Legal maneuvers such as Valsalva maneuver, cuff, gag, cold water treatment, and hold your knees against the chest. Administration of adenosine, antithrombotic therapy, and electrical cardioversion. Prognosis. The prognosis for patients with difficult atrial flutter who undergo catheter ablation is excellent, with a very low recurrence rate. Nursing diagnosis: ineffective tissue perfusion. Risk factors may include decreased cardiac output, planning and desired outcomes. Patient will demonstrate behaviors to improve circulation, display vital signs within acceptable limits, dysrhythmias is absent or controlled, and no symptoms of failure. Nursing interventions. Monitor vital signs, especially pulse and blood pressure, every 5 minutes until pain subsides. Assess the response to medications every 5 minutes. Monitor cardiac rhythms and patients monitor and results of 12-lead ECG. Provide oxygen and monitor oxygen saturation via pulse oximetry as ordered. Teach patient relaxation techniques and how to use them to reduce stress. Nursing diagnosis. Decreased cardiac output related to alteration of rate, rhythm, and conduction. Desired outcomes. Within 30 to 60 minutes of intervention, the patient will have improved cardiac output as evidenced by heart rate of 60 to 100 beats per minute, blood pressure of 90/60, and normal sinus rhythm in electrocardiogram. Nursing interventions. Monitor blood pressure and pulse. Assess patient's heart rate and rhythm in cardiac monitor. Assess the patient every 4 hours for increasing heart rate, increased blood pressure, fatigue, or chest pain. Inspect skin for pallor and cyanosis. Monitor urine output, noting decreasing output and concentrated urine. Nursing diagnosis. Deficient knowledge related to lack of understanding about interrelatedness of cardiac function. Desired outcomes. Identify relationship of ongoing therapies or treatment program to reduction of recurrent episodes or prevention of complications. List signs or symptoms that require immediate intervention. Identify own stress or risk factors and some techniques for handling. Initiate necessary lifestyle or behavioral changes. Nursing interventions. Discuss normal heart function. Include information regarding patients' variance from normal function. Discuss importance of being as active as possible without becoming exhausted and of rest between activities. Discuss importance of sodium limitation. Provide list of sodium content of common foods that are to be avoided and limited. Encourage reading of labels in food and drug packages.